All right, good evening once again. Welcome to our CPD meeting. I guess the others will join in once we have started. They'll join in as we continue. We're going to go ahead with our meeting and to start our meeting. Our lecture today is on adhesive dentistry, and Dr. James Nind is going to be presenting this topic. He's a qualified dental surgeon from the University of Zimbabwe. He qualified in 2018 and is currently practicing in private practice, working as a family dentist. So I'll leave this time to Dr. James Nindi to take over and to take us through adhesive dentistry. This is the part one of the lecture. I believe the other lecture will follow in the other weeks that will follow. Thank you so much. Over to you, Doc.
Thank you very much, Dr. Zaini. Just to confirm before I begin, am I loud and clear?
Yes, you are.
Yes, loud and clear.
Okay, that's fine. And please confirm if my screen is fully visible.
Yes, it is.
Okay, thank you very much. Okay, good evening, everyone. Thank you very much for logging in. As Dr. Mzaini said, my name is Dr. James Nindi. I qualified at the University of Zimbabwe in 2018. I'm going to be taking you through two parts to a series on principles of adhesive dentistry. So this first part, we're going to talk about principles of composites. Okay, so basically this is the outline of this first part. We're going to define adhesion, talk a bit about the anatomy of enamel and dentine, which is the tooth structure. We're going to talk about the history of adhesion, components of adhesive systems currently, clinical classification of the adhesive systems. We're going to give a few examples, and then we're going to summarize everything in this first part. So before I begin, for some of us, if not most of us, this will be like a review because these are things that we do on an everyday basis. But I don't know for some of you, but for me, when I qualified, I knew what I was supposed to do, but I didn't know why. So knowing the science will help in the practice of clinical dentistry. So this is the outline of the lecture. To start off, we're going to define what adhesion is. Adhesion is basically the joining together of two objects. Right. So by understanding the history of adhesion, we'll be able to appreciate the current adhesive systems and anticipate what lies ahead, anticipate what lies in the future of adhesive dentistry. So to start off, we're going to talk about the anatomy of the tooth structure that we deal with in adhesive dentistry. We have the enamel and the dentine. So enamel basically contains 3% water. Dentine contains more water, to be specific, about 10%. Right, so the picture on the right, that's Dr. Michael Bonopo. He's a pioneer in adhesive dentistry, and he discovered the effect of H-shaped tooth structure and how it helps in adhesive dentistry. So how he discovered it, he realized how phosphoric acid is used. It is applied on walls, on some surfaces. So he decided to experiment, play around with the phosphoric acid, but with regards to dentistry. And what he discovered that in enamel, when you etch enamel, it results in the superficial demineralization and dissolution of the enamel rods, thus creating more porosities. And in dentine, it results in the exposure of collagen fibrils and the collagen interfibrillar spaces. So you might be wondering why he might have decided to use phosphoric acid. It's because he just decided to use phosphoric acid because that's the one that was used in painting. But there are current research that is being done on the use of citric acid, malic acid, as well as many other acids. But currently we're using this phosphoric acid. And why 37%? Why have scientists decided to use the concentration of 37%? Is because they discovered that concentrations of less than 30 or more than 40 will result in the precipitation, resulting in crystal formation, and this will affect bonding. So a concentration of between 30 and 40%, it was discovered that it is enough to etch adequately the tooth structure. So how long do we etch and how do we etch? So as we're going to discuss later on, we'll realize that in enamel, right, because of the superficial demineralization, we have to etch for 30 seconds. And in dentine, we etch for 15 seconds. So why did Dr. Boanopo take all this time to research about etching and adhesive dentistry? Now let's go into the history. So I've decided to use schematic diagrams to try and bring the point home for us to be able to understand what adhesive dentistry is all about. So before I begin, I'll just talk about how amalgam was the gold standard for restorations in posteriors, and in anteriors, they usually used methacrylate resins. So composites came in and revolutionized restorative dentistry because of the ever-rising demand for aesthetics in the patient community. And more importantly, the advocacy for less extensive cavity preps and the preservation of tooth structure. So composites were excellent, but they have one inherent problem of polymerization shrinkage, which we'll discuss in the next lecture. So there was a lot of research done to attempt to reduce the gap between the tooth and the composites, because at first they never applied anything on the tooth structure. So if you see on the schematic diagram there, there's a key on your right. There was just the tooth after the cavity preparation, and then they would just apply the composites without any etching, without any bonding, right? But they discovered that when you apply the composite on top of the tooth, there will be spaces in between the composite and the tooth. And this was a major problem. So scientists went on to do more research on how they can reduce these spaces. And then in came people like Dr. Michael Boanopo, who discovered the use of phosphoric acid on the teeth. So they also discovered that on teeth, we have a smear layer, which is basically the organic material that remains on the teeth after cavity preparations. So to remove the smear layer, they decided to first use a weak acid to remove it, for the composite to come closer to the tooth and occupy the space, right? So far, the resultant effect was there being two steps, the etching and the application of composites. But then there was a problem. This composite that you see here is too viscous to occupy these spaces. So then scientists said, we need a less viscous material which can be able to flow into these spaces. So in came the bond. So this bond is made of resin, but it's less viscous than the composite. And as you can see, there was a bit of progress with regards to occupying this space between the composite and the tooth. So now we have three steps. We have the etching, the application of the bond, and then the composite. But still, there was a problem. They were following the same step for both enamel and dentine, of which it wasn't possible because of the different water content in the tooth structure. Now, as I've said before, enamel has less water content and dentine has more water content, whereas the resin that we use is hydrophobic. So this difference with regards to the affinity to water content affects how we bond. So they decided to introduce another material which can be able to form a bridge between the hydrophilic dentine and the hydrophobic resin, which was called the primer. So the primer basically functions to bridge the gap between the dentine tooth structure or the enamel tooth structure and then the resin. So this helps in occupying the space between the tooth and the restorative material. And as you can see, there was a bit of progress. So with regards to history, we've come a long way from just applying composite on the tooth, coming all the way to having three steps, which are etching, priming, and bonding, right? So I'm not sure if this schematic diagram was clear enough. If there are any questions, please put them in the comment section, and then we'll try to address them right at the end, right? So that's a bit about the history. Now we move on to the future. What does the future of dentistry look like? So according to literature, there's some research that is going on where they're trying to come up with self-adhering composites, where after the cavity preparation, you don't have to etch or bond, you just apply the composite. Apparently, it will have properties which are fit enough to be able to bond to the tooth structure without any prior preparation. So currently, where do we stand? So current components of adhesive systems, right? An adhesive system typically contains resin monomers, curing initiators, inorganic fillers, as well as solvents. So every component has a specific function. The resin monomer functions to be able to bond the dental bond to the composite. Curing initiators, as we'll discuss in the next lecture, they function to be able to turn the resin monomers into polymers, resulting in a solid which can be able to bond to the composite. Inorganic fillers function to enhance the physical properties of the adhesive, and then solvents function to enhance the properties of the primer. So as I had said, the primer functions to form a bridge between the tooth and the composites. Now, these solvents act in a way for us to be able to know whether we're going to perform a restoration using wet bonding or dry bonding. So there are various solvents that you can use. They can either be water-based or ethanol-based. So what will we want to achieve in either wet bonding or dry bonding? Okay, so when you're performing a restoration, you etching, you have created the microporosities. In these microporosities, we want to occupy as much space as possible so that we can minimize issues like post-operative sensitivity. So depending on the adhesive system that you'll be using, there are two ways in which you can do this. You can either do it as wet bonding or dry bonding. The particular adhesive that you're using is ethanol-based. What it simply means is that after etching, right, you dry the dentine, but you leave it visibly moist. A common way in which people do this, they put a cotton pellet or a rolled cotton roll into the cavity preparation, and then you dry out. When you remove the cotton, it will be visibly moist. That's wet bonding. And it's applied in ethanol-based solvents because the idea is that when you dry the cavity preparation, right, the ethanol will then function to chase out the excess moisture. And then when you chase out the excess moisture, the ethanol would then allow the resin in the bond to then penetrate the spaces, and then you can then continue with the restoration on top. And then the dry bonding is mainly applied in water-based solvents, where after etching, you completely dry, so that as you can see in the picture here, the collagen interfibrillar spaces will collapse, and then there's a dense mat that is formed here. And then the water in the solvents will then function to re-expand the collagen fibers, and then we can then continue with the restoration. So that is basically the difference between wet bonding and dry bonding. It's basically determined by the content of the solvents within the particular adhesive, right? If the adhesive is an ethanol-based solvents, you use wet bonding, where you dry the dentine, leave it visibly moist. If you have a water-based solvents, you dry out the dentine, and then you continue with the restoration. Okay, now we move on to the clinical classification of adhesive systems. So basically, up to this point, we know that we have 3 steps: etch, prime, and bond. So all adhesive systems zone around these 3 steps. So we can classify adhesive system by the number of clinical steps, classify according to etching method, and classification by generations. To start off, classification by the number of steps. As you can see in the picture there, we have 3 steps, 2 steps, and 1 step. So if it's 3 steps, every component in the adhesive system is separate. The etch will be separate, the prime will be separate, and then the bonding is separate. We can have 2 modalities. Basically, it means one of the 3 steps has been combined with the others. So one form of the 2 steps is the etch, where the etching component is separate and the prime and bond is combined into one. And then we have another modality of 2 steps, where the etch and the prime are combined to form the self-etching primer, and then the adhesive is separate. And then we have 1 step where the etch, prime, and bond will be combined into one. So this is one way of classifying adhesive systems. Another way of classifying is by H modality, whereby there's simply two ways. It's either it's H and rinse or self-H. The difference being in the H and rinse, the acid H is a separate step, and then in self-H, the acid is combined into one of the steps. So it's either H and rinse or self-H. Then finally, we have classification by generations. So this classification was mainly due to the increasing complexity of the bonding agents. So we have the first to the third generations, which are now widely used. Personally, in my experience, I haven't seen a first, second, or third generation adhesive system. So these ones were ruled out because, as you can see on the right, the shear bond strength was low. So when we discuss the composites, we'll understand the relevance of needing a high shear bond strength in adhesives with regards to the composite that you use. So from the first to the third generation, the shear bond strength was low, hence they're no longer used and they're no longer on the market anyway. And then we have the fourth to the eighth generation. So as you can see, the etching modality is included as well as the number of steps. But on the etching modality, I'll just need to expand a bit more on the various kinds of etching modalities that I'll need to define. So we have total etch and selective etch. The difference is in the two structures that will be etching. In total etch, we'll be etching both enamel and dentine, and in selective etch, we'll be etching only enamel. And then we have etch and rinse and self-etch, which I've just mentioned, where etch and rinse, the acid component is separate. Then in self-etch, the acid etch is combined into one or both of the other two components, the prime and the bond. So from the fourth all the way up to the eighth, the whole idea is an increase in complexity of the bonding agent and in reducing the number of steps, thus increasing the ease of use. So the gold standard was the fourth generation, which has 3 steps, which is the H, the prime, and the bond, right? The reason why it was the gold standard is because when you use the fourth generation, you have separate components and there's an increased level of trust in the restoration that you do. It's different from the rest, from the fifth up to the eighth, where you have components mixed together. Hence, there's an increased complexity on the ease of use. But in as much as the fourth generation is the gold standard, the major disadvantage of the fourth generation was that it was time consuming. So because of that, scientists decided to go and discover more and decided to mix one or more of the components together, hence the reduction in the number of steps. But then as you can see, the 8th generation, the bond strength is over 30. And then there are studies that have been done whereby they discovered that the shear bond strength of universal adhesives was increased by pre-etching both the enamel and the dentine surfaces with phosphoric acid. So if you read that statement, it says etching both enamel and dentine. If you etch both enamel and dentine, that is total etch. But here it says self-etch adhesives. So with self-etch adhesives, yes, you can use these universal adhesives in the self-etch modality, but they discovered that by etching both the enamel and dentine, by etching using the total etch modality, you can increase the bond strength. And that is what we're currently using when we're using universal adhesives. You etch both the enamel and the dentine. You first etch the enamel for 15 seconds, and then you go on to etch the dentine for 15 seconds. But then you leave the etch on the enamel for an additional 15 seconds to make 30. Hence, in total, you etch the enamel for 30 seconds, etch the dentine for 15 seconds, and then you then apply the bond. By using this method, shear bond strength, they've discovered that it goes to over 30. Now, these are examples of adhesives. We have a 4th generation OptiBond, we have the separate prime, the separate adhesive, and then 5th generation Ruby bond, which is the total H, 2 steps. And then we have the 8th generation, 2 examples there, the Scotch bond universal and the tetric end bond universal. Of course, the examples are many, but these are just the ones I decided to include in this lecture. Now, I tried to make this short so that at least if there are questions, we can try to address them, right? So this is basically a summary of everything that I've been referring to. So if you understand this slide, you can be able to depict how to use any adhesive system on the market. So how to do the adhesion properly? First of all, you need to know the adhesive system, right? Whether it's fourth, fifth, sixth, seventh, or even eighth generation, whether it's etch and rinse or self-etch, whether it's 3-step, 2-step, or 1-step, and then know the components, especially of the primer, for you to be able to decide whether you're going to use wet bonding or dry bonding, right? So as you can see, on the rows, we have the number of steps, and then in the columns, we have the etch and rinse. Combination of the rows and the columns, you can be able to depict any generation. Sorry. So we'll try to go through in an adhesive system is 3 steps, and is the etch and rinse modality is the 4th generation. So why is it the 4th generation? Is because you have the etch, prime, and bond, 3 steps, and the etch is separate, so it will be etch and rinse. If you have 2 steps, it being etch and rinse, it will be a 5th generation. So why 2 steps? Is because since here is etch and rinse, the etch will be separate, but the prime and bond will be in one bottle. So you have the etch separately, prime and bond in one bottle. That is 2 steps. And then here I put in X, because if you think about it, we can't have 1 step when it's etch and rinse. Because if it's etch and rinse, it means the etch is separate. So once you have the etch as a separate entity on its own, it means you have more than 1 step. So we have nothing here. And then moving on into the second row, if you have 3-step self-etch, it's not possible, because when we're saying 3 steps, we're saying there has to be etch, prime, and bond. And if it's self-etch, we're saying the etch has been combined into one of the others. So that being the case, we can't have 3 steps as self-etch, so we put in X here. Now, if we have 2 steps, it being a self-etch modality is the 6th
one I thought.
Was that a question?
I don't think so, Doc. You can continue.
Okay.
Can you please mute our phones? Thank you.
Okay. Now move on. If it's 2 steps, as self-etch is the 6th generation. It's because in this generation, we don't have a separate etching modality. We have the self-etching primer, and then we have the bond as a separate step. So it's 2 steps. And then if it's 7th generation, we have the single step, it being a self-etch modality, because this etch, the prime, and the bond have been all combined into one. And then over and above the 7th generation, we have the 8th generation adhesives, which are also known as universal. So the difference between the 7th and the 8th generation is that in 8th generation adhesive systems, they incorporate nanoparticles, which basically enhance the physical properties. So if you just look at this slide, you can be able to buy any adhesive on the market and be able to depict how you're able to use these adhesives. So I've noticed some adhesives come, like for example, the Scotch Bond. It comes and it says Scotch Bond Universal. If it's universal, you know that you use it in the self-etch modality. But as we have discovered, according to the studies that I've mentioned, you can use it in the etch and rinse. So currently, if you're using the Scotch Bond, you finish your cavity prep, you etch the enamel for 30 seconds, etch the dentine for 15 seconds, and then apply the adhesive. In applying the adhesive, most of these adhesives are acetone-based. So meaning that you have to employ the wet bonding. So in wet bonding, remember, you don't have to over dry, you have to leave it visibly moist. So in leaving it visibly moist, you make sure that you don't collapse the collagen fibrils, and you maintain the collagen interfibrillar spaces for the primer within the bond to penetrate, resulting in the formation of the hybrid layer, and then you can then put the composite on top. So try to make this short. This is basically the summary of the adhesive systems. If there are any questions on this, we can be able to address them. But before I finish off, I just want to highlight something with regards to isolation. So this is a study that I came across recently, basically clinical in situ evaluation of the effect of rubber dam isolation on bond strength. What they basically did is they took two scenarios. One scenario where they did a restoration without rubber dam, one with rubber dam, regardless of the adhesive system. And the results were as follows. They discovered that use of rubber dam results in an increase in the shear bond strength versus not using a rubber dam. So that's just it. The conclusion was absolute isolation of rubber dam increases bond strength to enamel independent of the adhesive system. So use of a rubber dam is absolutely paramount to regard the success in adhesive dentistry. So that being said, I've come to the end of this first part. I'm not sure if there are any questions. If there are, I'll try to address them. Dr. Mzaini, do we have any questions?
Thank you, Dr. Nindi. Colleagues, if you have any question, you can kindly unmute yourself and go ahead, or you can type in the chat box. I'll also be checking if there are any questions that have been raised in the chat box. In the chat box, basically people are commenting brilliant presentation, clear and concise. And someone now said true and excellent presentation. People always say that if there is no question, it's either the reason is between two things. It's either people had everything or nothing was had at all. I'd like to think the first one to be the reason. Okay, someone is typing. Let me just check. Lovely presentation, excellent teacher. Good teacher, it was clear. Agreed, excellent presentation. Looking forward to the next one. Great presentation. I presume there are no questions. Maybe, Doc, you could maybe highlight to some people. It's not a question, but maybe to help where people can get some of these adhesives locally or wherever. That could help people to know where they can get some of the examples and practice them in their surgeries and practices.
Okay.
Sure.
I'm sure there are local shops and local suppliers who buy stuff from South Africa and then they come and sell here in Zimbabwe. I know of a few names. There's one called Simba from Cute Dental, and then we have Russell who works at Long Chain. So personally, most of the adhesives that they have, well, as far as I've seen, is they have the universal 8th generation adhesives. I'm not sure if they have any 4th generation or any 4th, 5th, 6th generation. I'm not sure. I only know of the universal. Personally, the only adhesives that I've used ever since I qualified were the Scotch Bond Universal and the Ruby Bond, the 5th generation. I haven't used a 3-step 4th generation etch and rinse adhesive system, so I wouldn't know where to get the local.
Can I make a contribution, please?
Yes, please.
Yeah, Doc, you can go ahead.
Yeah, thanks. The ESPE is a universal adhesive. That one is high end. However, the T economy adhesive that we're all using is also a universal one. It's just the packaging. Yes. But it's very good. And I think most of us are using T economy. Mm-hmm. So that adhesive you have in there is not any inferior. It's just that, it's been packaged for us in this part of the world. The manufacturer Avoclab, Vivadent is very good, and we should be confident in using it all the time. Excellent presentation, Nindi. I will tell you, I listened to it and I really enjoyed it very much. Okay, but one of the things in terms of composite, where most of us are getting our sensitivity, is probably because we overdry the tooth. That's why a lot of the patients are getting pulpitis. The other issue will be if isolation, as you rightly talked about, if the working field is not isolated properly and you get contamination, you would certainly get some form of leakage and pulpitis as well. But apart from that, excellent presentation. Thank you.
Thank you very much, Dr. B.
Okay, thank you so much. Are there any other contributions? Questions, contributions, additions, subtractions, you name it? Okay. I would like to believe there is nothing. Thank you so much, Dr. Nindi, for the lovely presentation. We're definitely looking forward to the next one. The part two. Is that a contribution or is someone who hasn't muted themselves? No, that's fine. It's not a contribution. I'll leave the time if there are any announcements to be done or to be made. Dr. Chingwena or the committee, if there are any announcements.
Good evening, Doc. I think at the moment we don't really have anything much otherwise to thank the speaker again for a great presentation.
All right, thank you so much, Doc. I guess it's an early evening today. Thank you everyone for joining. We'll see you next time. Have a good evening.
Thank you very much, everyone. Enjoy the rest of your evening. Good night.